All right, joining us today is Joe Jeffries. He's a pharmacist and director of pharmacy at FRX Health, medical cannabis dispensary in Ohio. And we're recording today. It's April 29th, 2022. I'm excited to talk to you today, Joe. I had you on the past. I don't know how long ago that was, but we did a one-on-one call and kind of talked about the business environment there.
Yeah.
That was really fun.
It was a cool conversation.
Yeah, and today we're going to dive a lot deeper into kind of some of the science and things you've noticed, being at the dispensary now for a few years. And I think what I like about your focus is taking kind of the higher level science and breaking that down for patients, what products to use for what ailments. And, as a pharmacist, it's probably a whole different world when other pharmaceuticals are standardized. Cannabis, they're going in and so many different products and choices and a lot of stuff there. So we'll dive into some of the science of that, and then we'll talk a little bit on the business side. I'm also curious on your background. I saw you spend 16 years as a pharmacy director at a hospital, so I always find that change to the cannabis side interesting, fascinating story for people as well. So thank you for taking some time today and coming on. I'm excited to chat.
Sure, it's great to be here. I sometimes describe myself as a recovering dissatisfied pharmacist. I keep changing venues, but I stick with them for quite a while when I do. But I've kind of seen it all.
Yeah. Let's start with that. So switching to cannabis, and we'll start on the science side, but I think it'll be a nice kind of introduction for listeners. That dissatisfied pharmacist, what was it when you weren't on the cannabis side, you were working as a pharmacy director, and then making that switch? Like, what triggers that? Because that's huge. And at the time, even now, I'm sure you still get some looks from your peers that are like, what are you doing? You're throwing your career away.
That is the number one question, no doubt about it. I mean, I actually grew up in a pharmacy family. My dad had a drugstore, and even at that point, I was dissatisfied. I didn't even want to be a pharmacist. I watched my dad working long hours, and I loved math. I thought I was going to be an engineer, and it turned out I like science too. And all the numbers say that's a perfect field for science and math, so I gravitated toward that anyway. And worked really in community pharmacy for quite a while before I became that pharmacy director at a hospital. And in the midst of that, opened up my own compounding pharmacy.
Okay.
That was a couple year stint. I did enjoy that. Probably the most similar to this cannabis pharmacy, but then I was a pharmacy director at a hospital for 15 years and just loved that interaction with the other professions. And, when I was in pharmacy school, really, they hadn't even discovered the endocannabinoid system yet. But it really started to come into play in the 90s. And boy, I was just so intrigued. I mean, now we know it's one of the largest neuroregulatory systems in the body. But, even at that point, even when you were studying it as one of the drugs of abuse, you could tell that there was so much potential with THC, CBD, and some of the other cannabinoids that we knew about at that point. So always had been intrigued by it, always intrigued by that system. And I would just follow it as much as possible. I visited dispensaries in Chicago, Connecticut, just to kind of see what was happening. In those cases, there were pharmacists involved. And gosh, I was like, this is like the perfect situation. It's rather than, in community pharmacy where the physician prescribes a medication, says this is the exact dose you're going to take, this is the exact frequency, and I just hand them that and do my best to explain that particular medicine to them. There really wasn't much, higher level involved in that. But now it's perfect. It's doctor diagnoses, recommends this drug class, and then it's up to me as the pharmacist to say what frequency, what dose, what route to use. So I absolutely love it, this part of pharmacy.
Yeah. With the ECS and kind of understanding the science of it or even its existence, was that just self-interest and like self-teaching yourself about it, and how, other pharmacists that aren't in the industry or even the doctor, just healthcare field, do you see them taking that system seriously now, or just curious but confused by it because it hasn't been such a focus for so long?
It's probably more curious but confused. I mean, unfortunately, it becomes a drug you test for to determine if someone's going to have a propensity for addiction. And so that's the context that most healthcare professionals
Mm.
see cannabis. And, that was another reason that while I was intrigued, when I was at that hospital, we had, I was in southeastern Ohio, part of Appalachia. Drug problem was huge.
Mm.
And right in the midst of me being this pharmacy director at the hospital, and there was a need. So I helped open an outpatient clinic for heroin and opiate addiction. And uh, 80% of our patients were self-medicating with cannabis. That was
Hmm.
another intriguing part. I knew, you know, that it's a non-toxic medication as well. So that, okay, this is fine with me. But again, as they entered drug treatment programs, that was kind of a red flag,
Hmm.
right?
Hmm.
THC was. As I was moving on to the dispensary life, I think that's becoming better, but it's still, I mean, to answer your question, yeah, I think we're still not quite there yet with most healthcare professionals.
Yeah, yeah. It takes a while to burn off that stigma of all those decades that war on drugs was created, especially around cannabis. And it's interesting now that some studies are coming out. It's shifting that are almost flipping that and saying actually the cannabis use for a heroin or opiate addicted person might lower their heroin or opiate use, balance it out a little, like kind of help them more than it's actually hurting them.
Well, and I think the what words people use now, it's an exit drug
Mm.
instead of a gateway drug.
Mm-hmm.
And I totally agree with that. There's a lot of, you know, uh, there people worry about kids and drug use, and really, I agree with the fact that kids, adolescents, should not use cannabis before the age of 25 in general.
Mm-hmm.
But any drug that a teenager takes uh, increases the propensity that somebody's going to be addicted as an adult,
Mm-hmm.
whether that's cigarettes, alcohol, whatever the case might be. So to blame cannabis for that, I think, is misplaced.
Yeah, yeah. So getting into some of the science, and I think some of the stuff you emailed me about ahead of time is really fascinating. And what you just see being in the dispensary or acting as a pharmacy director, there's nothing that replaces, I think, that in-person, face-to-face interaction with the actual patient. So um, diving in, there's some specifics around like the CBD you mentioned being maybe an anandamide reuptake inhibitor and kind of those specific kind of mechanisms. But I thought to start a general kind of what you're seeing as common themes with your patients and maybe even what Ohio, because I know it's just medical, how restrictive they are, and what's that kind of diagnoses that they're allowing, or what's the most common you're seeing coming in.
Yeah. So, it originally started out, the law was passed in 2016, and then everything sort of got implemented starting in 2019. I think there were 21 qualifying conditions at that point, pretty typical from what you see in other medical states.
Mm-hmm.
Um, the most common, in Ohio is just like most others, chronic pain. PTSD is second. We have an intake form that patients fill out that we try to kind of dive into their medical history a little bit more, and we talk about what other comorbid conditions the patients have that their doctors actually diagnose, and what other issues they're facing. I think that's fascinating, and it gives us a chance to talk about it. Now, you'll notice that for whatever reason, in most medical states, I don't know if there is any. You probably know this better than I do, but there's no states that have insomnia as one of the potential qualifying conditions.
That is
Uh,
interesting. I don't
I
think I've
know,
heard that listed either
yeah,
anywhere.
depression is always controversial, but the reason I bring those up is because other diagnoses from physicians, 69% of our patients have depression as a co-existing uh, uh,
Interesting.
condition.
Yeah.
Anxiety is like 63% when it comes to other symptoms that patients are experiencing. Once again, another issue that obviously the majority of our patients face, but it's not a qualifying condition. I think that would be a game changer in Ohio. I think Pennsylvania does have that as one of the qualifying conditions. Pennsylvania is also progressive in that they have opioid use disorder
Mm.
as one of their QCs, but Ohio just hasn't gotten there yet. I submit the studies and everything, whether it's from Canada or wherever, to try to get anxiety added, but it's been a frustrating experience dealing with our medical board that kind of makes those decisions along with the board of pharmacy.
Yeah. It's interesting. Yeah. So anxiety is maybe not allowed, but you've noticed 63, very high percentage of your patients are dealing with that, but it's some other chronic condition or something that they got approved for a qualifying condition, and struggling with that.
Right. Well, and it's usually back-ended with PTSD.
Mm-hmm.
A patient that has anxiety, they'll probably talk to a counselor at one of these physicians' offices and, kind of determine that PTSD is part of their symptomatology.
Yeah. Yeah. And those categories get very difficult to, like you said, even depression, it's very hard to say you have it, you don't have it versus something that's more black and white. Is there a separation between like a condition and a symptom? Are those thought of or viewed differently?
Well, only in the sense that we ask for both sets on our intake form. If a patient has a specific condition diagnosed, I mean, you could kind of hang your hat on that. If a patient just says one of their symptoms is anxiety, I'm not sure whether you can, take that as gold or not. There's no diagnoses actually.
Yeah. Yeah. So with those most common conditions, what are you seeing around maybe product use, dose, or anything that kind of stands out that's becoming a recurring theme?
Well, when we meet with patients, especially cannabis naive patients, I like to talk to patients in terms of, onset of action and duration of action. And I love to sort of have the combination of those two on board, at least at the beginning for them. So, look, you need something quick acting, and it'd be nice if you had something long acting, especially when it comes to insomnia, right?
Mm-hmm.
I mean, and then you can get into some of the effects of particular products being more sleep inducing. I'm being very careful not to use the words indica and sativa with you.
Oh yeah.
No, I'm glad you put that podcast forth because it is so passe right now. But
is it common there as well?
Well, I
Patients
mean,
are
we still
asking?
define it that way here in Ohio. It's a shame. But what I always say though is I never would tell somebody to take something labeled as an indica during the day, and I usually would not tell somebody to take a sativa at night. But always with that qualifier is everybody reacts differently to those type of products. But my point being, I'll try to do a quick acting and a long acting, and that's usually vape and edible.
Mm-hmm.
But oftentimes, patients just don't want to inhale, or they have that perception that inhaling might be bad, or they just don't want to do that. So the next obvious step would be tinctures or drops sublingually. And that, I usually tell people that's a half hour, 45-minute onset and about a 4-hour duration. And then edibles, I usually tell them it's about a 2-hour onset and a 6-hour duration. And then from there, we determine what milligram would be most appropriate. Since most products are 10 milligrams in general, I usually tell them to start at a quarter to get 2.5 milligrams and then kind of build up from there.
Yeah, especially that's probably another filter is first time consuming or haven't in 20 years, or have you been regularly consuming, off the radar maybe, and more familiar with your control, your tolerance and things like that.
Well, one of the most important questions on our intake form is what's your history of cannabis use? I mean, if someone's been using for 30 or 40 years and currently using, I'm not so concerned about starting them at 2.5 milligrams. But oftentimes people that have just been, heavy smokers for years can't handle edibles very well. So even in that case, I'm cautious with them and just explain that, you probably should, first of all, it's more economical. If you can get away with 5 milligrams, wonderful. Then you got 20 doses in your 10 dose bottle and work out better.
Have you seen most patients going to the higher THC products, or are in Ohio high CBD, maybe really low THC or hemp type products? Are those popular as well?
Well, it's a lot of times with those cannabis naive patients, those high CBD products are a nice go-to. I had a caregiver for a patient. Guy was had a stroke not too long ago, really struggling. And she was telling me during the consultation that I think he was nonverbal also, that he got high on hemp milk, and I didn't argue with her, but it was nice to be able to go with, there's, I'm going to say 20 to 1. I'm not sure,
Sure.
most of your our viewers or listeners, for whatever reason, we do the CBD first and then the THC, the way we describe products here. But anyway, we have a 20 to 1. That's a nice option for those type patients. There's also, 5 to 1s as well that you can do. But for the most part, patients are gravitating toward high THC, not necessarily that they want to get super high, but that it's more economical. Basically, they can get more bang for their buck.
Yeah. Yeah. That's interesting. Have you seen a condition where the high CBD hemp products and sticking with a really low amount of THC seems to be the most applicable for people?
Um,
Or is it kind of across the board, just case
yeah,
by case?
it's
Hard
kind
to tell.
usually I start at 1 to 1,
Yeah.
and then either up or down from there. Now, I just had a patient yesterday. It's another caregiver caring for her elderly patient, her elderly parent with dementia, and we started at 5 to 1 for her.
Mm.
5 times 5 CBD, 1 THC, just to be more cautious. She had complained about some of the other. She's on a medication called Seroquel, which I just can't stand in the elderly, just because it's so powerful. It's often used in nursing homes, but she tends to get zonked out. So I did not want the THC to be too high in her case, because I didn't want that same thing to happen as we started out.
Yeah. What is Seroquel? What's that drug used for, or how does that work?
Well, it's defined as an antipsychotic,
Antipsychotic.
and it's sort of become the new Haldol in nursing homes. We try to get away from chemical restraints in nursing homes, and unfortunately, I would put that in that same category. We see patients sometimes taking 300 milligrams of Seroquel at night, and it just knocks them out.
Yeah. Do you see many pharmaceuticals, whether it's in senior homes or other places, that are intended to work on the ECS in any way? Or does, cannabis, clearly that's its main acting mechanism. Are other drugs doing that, or are they normally taking other routes? Because it seems like they're all trying to, even Seroquel, right? Calm a senior down, sleep well through the night. It's really sounds like it's trying to solve those issues.
Yeah, it is. And, we're probably a little bit ahead of our time when it comes to group homes or nursing homes or Alzheimer's wings. But gosh, that's one of my goals. I hope that we can get to that point where we can do a study with patients with those drops. The only way that cannabis has been studied in that type of patient is what we call nighttime excursions. And when they did a side-by-side study, randomized controlled, the nighttime excursions decreased with the cannabis dosing. I think it was 1 to 1 in those cases that was the most effective. And there's so much potential there without the severe side effects associated with those other meds we're talking about.
Yeah, yeah. Yeah, or even back to like what we were saying about opium, potentially cannabis use much lower doses of those other meds if they're still needed or could be used in that way.
Oh my gosh, we could have a whole nother podcast on that. It's just back to the physicians not quite understanding or kicking a patient out. Like pain clinics is a great example where it's this binary all or none. You're either, well, if you go on THC, you're done with me, or whereas it could be such a great adjunct to use with opiates, to decrease the dose and the side effects of the opiate.
Yeah. Yeah, I heard someone, or maybe it was a past podcast, talking about either whether it's a high THC cannabis or hemp being kind of like a daily multi-use vitamin for once you're in your 80s, 90s, and eventually once we get through all this fog and clearer on the science, I wonder if you're gonna, 20 years from now, walk into an old folks' home and it's not gonna be a party, but there's certain rooms there's gonna be smoke coming out, and it's because almost every senior at that age, especially when you get near the end of life, it's so many people that it would help, I would think.
Right, and there's a curve of people with the stigma as well, becoming, these baby boomers now, which I'm kind of one, will kind of gravitate toward that as a medication.
Yeah.
I think more.
Yeah. Um, and I was asking about, lower THC use, where that might be a fit, because I think for where there is stigma, certain places, that's kind of a nicer approach in to this field and area. And you sent me an email, or when we emailed, you said CBD being an anandamide reuptake inhibitor. And I was wondering if we could talk about that, exactly what that mechanism is. And I think I'll wait. I have another question on that, but I'll wait to ask that one.
Well, Cody was saying it best on your previous podcast. If a medication is an agonist at a receptor versus an antagonist, or a receptor blocker. I mean, we're in pharmacy. We're so used to, drugs like ACE inhibitors, which stands for angiotensin converting enzyme inhibitor, which blocks an enzyme. And then there's a whole nother class along with that are called angiotensin receptor blockers. So it basically blocks the receptor and allows the whatever neurotransmitter you need to be more active to stay in the bloodstream to activate. So, in the case of CBD, it's basically increasing the amount of your own endogenous cannabinoid, in this case, anandamide, to act on the receptors. And I don't know. I think that makes it. It's almost more holistic that way. It's almost
Right.
it's kind of cool. I've always wondered why we had this plant sort of coincide with humans in this way, but who knows? Maybe that's one of the reasons.
Yeah. Well, it also makes you wonder, 100 years, I mean, cannabis, thousands of years of use, Chinese medicine. I always wondered what strains and what genetics and what profiles were in those plants, because it was really the black market, right, that developed these super high THC strains. I heard CBD was almost bred out of genetics because, one, nobody's like potency testing at a lab. They're just selling like moonshine liquor. You want it as strong as possible. What other cannabinoids, or maybe THC was around, but it wasn't the most common, or you just don't know what was in those old genetics that have just been lost to time because of the war on drugs.
Exactly. It's a shame. And gosh, it just becomes such a point of contention is probably not the word, but it's something that you have to get past with a brand new patient.
Mm.
As you're talking to patients that have used cannabis forever, they don't even know if they've had CBD in the plant product that they've used, number one. And if they have used CBD, they either turn their nose up because they said it didn't work, because it really doesn't have a psychoactive effect. So it takes forever to get past that, and then you have to deal with the whole other variable of how much quality went into that product that they purchased that had CBD in it.
Mm-hmm.
But we have a few actually flower that's grown in Ohio that's all CBD. It's kind of cool to be able to recommend that to patients who want to use the plant based product.
Yeah. Was so it makes, with if CBD is an anandamide reuptake inhibitor, it feels more like kind of the supplement multivitamin in that scenario, where it's continued daily use, and then over time it's like kind of like taking vitamin D. It's hard to see like the effects versus THC, right, which is very obvious. And so I wonder if it works, if it's kind of its use case is more in that light, if that's how it's working.
Sometimes I'll even describe it to patients that it kind of acts like Tylenol. You just sort of believe that it works, but you don't feel anything from Tylenol. But we know, scientifically that it does work. And quite frankly, as you know, CBD's been more studied than THC when it comes to the science.
Right. Yeah. More access, easier to study it. Do you know, was there a study, or was it shown in like a petri dish that it acted as a reuptake inhibitor, or anything further that showed like anandamide levels were 20% higher when consuming CBD for a month with this dose, or something like that?
I think there's definitely in vivo studies. My inbox is filled with, I somehow got on a listserv of the multiple studies with cannabidiol and THC. And some of the other new cannabinoids as well. But man, there's just a ton. Like I would say 10 times as much with CBD.
Yeah, that comes through.
Yeah.
Something else you mentioned, recent patients that you had come in actively seizing with epilepsy. Does that mean they were coming on site while having a seizure, or had a seizure while on site there?
Yeah. So this kind of plays into, the need for a healthcare professional. I'm constantly, my job is often remote at this point, and I had always I was at the dispensary 7 days a week when we first opened,
Mm-hmm.
and while it was tiresome, it was still pretty cool to be able to see every patient and discuss things with them. You sort of recognize when, kind of your expertise was needed. But now I have to train the staff. We call them dispensary technicians at our place, to, recognize when it's kind of gone to another level. And this was a perfect case. I mean, he came in with a caregiver. The guy actually used to live in Colorado as well, and um, he was definitely it was petit mal seizures, but they were just constant. I mean, over and over and over again, and the caregiver kind of had to hold on to him, but he was able to kind of verbalize what he'd used in Colorado, and so it kind of helped me. I didn't know what the ratio was of the cannabinoids, so in his case, we started, as CBD is definitely the most appropriate cannabinoid to use in seizure control, and we started. I gave him a 1-to-1 and a 5-to-1, thinking that in Colorado we probably had more THC.
Mm-hmm.
Because the other thing that they told me in the history is that the family was able to kind of calm him down. So I just kind of inferred from that maybe the THC content in there was helping in that regard.
Mm-hmm.
But then also gave him the 5-to-1 just in case maybe the seizures became worse or something on that. And I we do follow-ups on our patients, and I was just thrilled to be able to talk to that caregiver about a week later, and they said that the frequency of the seizures had decreased and the severity as well on the 5-to-1.
Interesting.
Yeah.
Have you seen another pharmaceutical that helps with, I mean, CBD and seizures? I mean, that's kind of what initially blew it up. Charlotte's Web, kind of that story of the younger girl that really went viral. Another pharmaceutical that helps seizures in the way that CBD seems to for a lot of patients.
Well, this guy, I think I tried them all. He was currently on a drug called Keppra, which is one of my favorite generic names, levetiracetam.
Hmm.
For some reason, I like to say that. And then he was also on carbamazepine. And, that obviously wasn't controlling his seizures. He had also just been to the emergency department and was getting, he had gotten Ativan or lorazepam injections to get the seizures under control in the ED. And then they discharged him on Ativan oral tablets as well. So Ativan is definitely a go-to in the hospital. And phenobarbital has been around forever. Dilantin has been around forever. It's always tough to figure out the dose of Dilantin because it has this crazy metabolism where it induces its own metabolism. So it's really hard to
Hmm.
figure out what dose the patient needs to be on. So, yep, another good reason that CBD could be, one of the best treatments we've ever had for it.
Yeah. Are the risk factors on those other drugs? I mean, the efficacy of the risk of taking hemp or CBD products, I mean, pretty low for most people. Are those other drugs, any of them have a similar like safety profile, or are they a more high risk
They're more high risk.
across
I
board?
mean, carbamazepine, the brand name is called Tegretol, and that can cause blood dyscrasias, where you have to get your white blood cell count tested a lot. Dilantin has its share of side effects. You know, it interacts with a lot of other medications. It does that induction of its own metabolism, but it also kind of puts you in a fog too. So
Mm-hmm.
it's oftentimes when patients are diagnosed with seizures, whether it's from epilepsy or stroke or car accident, even they can't drive until the doctor clears them to drive. They have to kind of stabilize on the dose. Um, so, gosh, there are just all sorts of benefits if we could get patients to, if we could find out whether, right now it's only approved in kids, right? That Epidiolex.
Yeah. Yeah. Is there do we know the direct mechanism of how CBD is helping so well with epilepsy for a lot of people? Because it sounds like these other drugs are higher risk and not targeting the ECS or working in that way. Do we really know what CBD is doing specifically?
Well, just the whole endocannabinoid system, in that it's retrograde. The synapse, there's retrograde kind of reaction in that synapse, where typically the neurotransmitter is released from the postsynapses, and now it's released from the presynapse, and it must recognize that there's an electrical signal that's gone awry, and with that whole concept of homeostasis, recognizing that there's too much electricity going on between those neurons, and
Yeah.
and hopefully increasing the amount of cannabinoids.
Yeah. So maybe the way to ask that is, what's the cause of a seizure? Because
Mm.
if it has to do with the ECS, or if that's been determined in science, it's interesting that these other medications don't seem to be directly targeting maybe where that seizure issue is actually the root cause of where that's coming from.
I don't know if we can say that yet. I bet you the ECS, gosh, I hate to keep referring back to Cody, but he's such a great resource,
Yeah.
and he was talking about that cannabinoid
Hmm.
and how the ECS plays a part in the other neurotransmitters. And, gosh, I mean, how many other neurotransmitters are there from, you know, norepinephrine to epinephrine? And I think they probably work in conjunction with each other, rather than saying the ECS is in total control of the electrical signals and
Hmm.
potentially epilepsy. It's probably a combination of all the above.
Right. And it sounds like now we're seeing like CBD are working in both those systems, or they're approaching both of them. So there's
In
multiple.
one way or another, yes, indirectly or directly. Yeah.
Yeah. Well, it makes me go back to like these current drugs we were talking about, and when those are developed, it's fascinating that cannabis are like, well, they want to isolate a molecule because if it's too many, it's like we don't know how it works. But these other drugs seem to work sometimes for seizures. There's large negative side effects, and if we don't even know the root cause of the seizure, how do these other drugs get approved that seem to be much more risky and worse when that you can't even explain those, scientifically? Sounds like.
Well, you have the luxury of, it being a pharmaceutical that has the potential to be studied, unlike cannabis right now.
Yeah.
And, they can do randomized controlled trials, and, must have figured out that the seizures were under better control than placebo in
Right.
most of those cases. And there are so many different types of seizures and epilepsy that, some target certain types of epilepsy than others. And then you have drugs like Neurontin or gabapentin, which was originally designed as a seizure drug, and then now it's almost exclusively used as a drug to treat neuropathies.
Mhm.
So again,
Interesting.
how do those systems work together? Why is Neurontin so much better for neuropathies than,
Right.
say, Dilantin? Uh,
Yeah, and I guess
Interesting.
those drugs, they're new. The names are new. They don't carry any of that stigma. So when you bring it's like a new discovery. Like no one's thinking like, well, for the past 60 years, that's been a drug of addiction. That doesn't play into that. So it makes it easier that way, and
Yeah.
is a factor. I also wonder how those drugs, when they study them, is it really just like they show better results than a placebo? But they list that long name of side effects, and it's like if it's 5% better than placebo, but the risk is huge, and it still gets approved. I mean, I guess it could still get approved. If you looked at the overall net score of it, you'd go, "This is a loss. We shouldn't do this." But if it's just a little better than placebo, it could be patented, potentially be a new drug on the
Oh,
market.
boy. It's always amazing to me. I mean, over the course of my career, to see how many medications that are still out there like that,
Mhm.
and how many ones that were approved and then taken off the market, like Vioxx, say. Um, it is, what, I don't want to completely poo-poo the pharmaceutical industry. I am definitely one that probably falls somewhere in the middle. I think we can find a great combination between Western medicine and Eastern medicine here with
Mhm.
these just like we talked about with, decrease, some patients are just going to need an opiate to treat their pain.
Hmm.
But if we can decrease the strength by using cannabis at the same time,
Yeah.
all the better
Yeah. Yeah.
without the respiratory depression.
Yeah. Yeah. Using both pull for, that's my, like, I don't know if it's more my engineering background, but like use the best of both systems and put those together. It's almost like the like socialism versus capitalism. Like, well, both probably have good parts we could borrow from. Like, why does it have to be 100% one or the other? It's like it's not
Exactly.
either or. We can use both.
A great analogy.
Let's kind of shifting over to the business side a little bit around edibles. So something else you mentioned was lobbying for the use of edibles in Pennsylvania.